Lee, do you hear me?
Yes, I can hear you.
Oh, that's nice. I think it's 5:30 for us, so I think that people are almost there. And I would like to introduce you to all the colleagues, actually.
Yes.
And before you give your presentation, we can record that, so no problem. We solved the little problem we had. I had to study 2 days to introduce you. So I think that I really would like to introduce you in an appropriate way and give you the importance and the credit you deserve. But I think it's very difficult to do that in 2 or 10 minutes. So, but anyway, I think that your talk is much more interesting than my introduction. So I will try to underline the most important things, or at least what I read in your CV. And you can correct me if I forgot something in this introduction. You graduated at Johns Hopkins University in 1966 and School of Medicine in 1970. So you have a huge experience with 8 years of additional training, 2 years of surgery, and 2 years research, and 4 years more. And if I'm not wrong, you are currently a professor of plastic surgery and professor of neurosurgery at the Johns Hopkins University School of Medicine. But you have a link, you have a connection with the Netherlands, not only with us, because I think you are the only American doctor having a PhD in the Netherlands, in Utrecht. About preventing ulceration and amputation in patients with nerve compression and diabetic neuropathy. You have a huge research behind you with a lot of models for peripheral nerve compression with silicone tube with the same internal diameter of the nerve, neuroma treatment by muscle implantation of a proximal end of a nerve, neural regeneration through absorbable conduits, diabetic decompression neuropathy, and your clinical work is focused on computer-linked devices to measure sensibility, and we had the honor to have one from you that's not available in Europe. Treatment strategies for pelvic and groin pain and treatment of symptoms of peripheral neuropathy related to nerve compression. Of course, your work elucidates all the stuff behind nerves and innervated joints and the treatment of joint and pain by denervation. You have 26 national research awards, 77 visiting professorship, and I hope that 78 is the one in Maastricht. We are busy with that and will be a great honor for us. More than 500 articles published in peer-reviewed journals and a lot of books. And I want to mention the evaluation of sensibility and re-education of sensation in hand, published in 1981, surgery of peripheral nerves in 1989, somatosensory testing and rehabilitation in 1997, pain solution in 2007, joint denervation 2019, and more and more and more than that. So, preparing this introduction, first of all, I felt my CV very little. I felt myself very little. And I thought that for us is really, really a big honor to have you with us. And I don't know why we have the luck to have this connection with you, but we feel very lucky and we don't want even to ask ourselves why. And I think that now we give you the word because everyone is waiting and is excited to listen to your talk. So please.
Okay, well, thank you very much. And we'll see if I can get the talk to work. Well, we have to did before. Are you seeing anything now? Can you see my screen or not?
Yes.
We can see it clearly.
Yes, perfect.
You can? Okay. So you see it very well?
Yes, we do.
Okay. So I had to find some pictures of Maastricht so you could see them. And let me see how I make this work. Yeah. Okay. So now it's working. Thank you very much for that beautiful introduction. And you were very kind to me. So I hope I can say something that makes sense and will be fun at the same time. So I'm going to start by showing you a puzzle. I want everybody to think about this because at the end, I'm going to ask you to answer this question. You see the picture on your left, is it the same or equal to this? I'm going to ask you, there's an immediate post-op picture and an 18-month post-op picture. At the end, I'm going to see who knows the relationship between these two things. That's all the clue you get. Now, we're going to talk about sensory testing. You can go to my website and you see the name, Dellon.com. Very easy. At the top of the page, it has free booklets. I wrote these for patients. They're only 3 or 4 pages. They're very simple. The end of each booklet has references. And these are all clinical problems, but we can get rid of these two. All the rest of these clinical problems require neurosensory testing, and that's what we're going to be talking about today. And you can download this little booklet, and although we're going to spend time talking about the breast, this sensory testing can be applied to the face. We have normal values for the trigeminal nerve. It can be applied, of course, to the hand and to the foot. And you see the references going back to 1997. We began working on evaluating this and showing that this was a valid testing system, the one we're going to show you today. And it has the name, the pressure specified sensory device. And then you see we went from the hand to the foot. And then heel pain. The plastic surgeons, we don't see this so much. But if you ever walk and your heel hurts you, this is a big problem. And the entire world thinks this is due to plantar fasciitis, but it can be due to the calcaneal nerve. And the foot doctors never measure the sensation in the heel. And if the heel has abnormal sensation, your problem's not plantar fasciitis. We then developed a technique to grade peripheral nerve problems. You're working with breast cancer, so you know there's a system for staging it. And I was the first to introduce staging of peripheral nerve problems. We can apply it to the brachial plexus. It's been used in many other countries. This is from Brazil for facial fractures. Here's the relationship between balance and sensibility in the foot. And here we have one that compares this to any other measurement of large fiber function. We've used it in the jungles of Ecuador to measure sensation in leprosy patients. And it can be compared to electrical testing. And later you can all ask me any more questions you want about more detail. But you are kind enough to mention my own work. I want to just mention that with regard to measuring sensation in the breast, this was first published from our group almost 20 years ago now, following breast reduction. It was taken up at Vanderbilt University, where this guy, where is he? He was our plastic surgery resident at Johns Hopkins and spent a year with me. They began to use it to measure breast sensation. They concluded that the pressure-specified sensory device was the best way to evaluate sensibility in the breast. And then perhaps you know Fabio Santinelli, who's been Secretary General for EURAPS and will be the president one of these days. I think when the meeting finally comes to Naples, he'll be president. And so he has used it actually to measure sensibility in the deep flap. And then these young men are researchers from Turkey working with Maria. I think you all know Maria Simenow, who did the first face transplant and who learned her nerve surgery with me. She evaluated every technique for measuring sensibility and decided that the pressure-specified sensory device was the best way to measure any sensation in the skin. Now, to get down to other work with the breast, here is a review, and this was their conclusion. Measuring sensation in the breast has been inconsistent because of the measurable outcomes across different studies. So although there's so many studies, it's hard to compare them because the outcome measures they use are so inconsistent. And then here's one from Stephanie working with Aldana. Aldana did her general surgery at Johns Hopkins, where I was. And she and I worked. Of course, it was really her idea to innervate the deep flap, but she used our technique for measuring. And I had the honor to present her work to the EURAPS Society, and that's where I called our work the sensational breast. And I give that name to Hansi if she wants to use it for her PhD thesis. And here's another one that Stephanie has done fairly recently. And so it isn't just my work. Stephanie has worked increasingly in this area, and she wondered how we came to be together, that I'm giving this talk in Maastricht. And I heard her present at one of the Peripheral Nerve Society meetings her work. And I thought that perhaps instead of using the Sims-Weinstein monofilaments, perhaps we could get her to use the pressure-specified sensory device. And to do that, to introduce everybody to neurosensory testing, is the reason we're giving this talk today. Now, she mentioned my first book, Evaluation of Sensibility and Re-education of Sensation in the Hand. And here I am as a young hand surgeon. This would be, I finished hand surgery in 1977. But this is how all the medical students are trained. And perhaps Dr. Lucas was trained like this. We're trained to stick people with pins and to use this little Wartenberg wheel. You all know Wartenberg was originally in Germany before Hitler came to power, and then he came to the United States and worked his way from instructor to professor at the University of California in San Francisco. So this is how you're trained to figure out where the lesion is in the central nervous system. None of these things are helpful for identifying peripheral nerve problems. And so what I came to realize during my training was that we had to have a measure of threshold and a measure of innervation density. And in the beginning, I used the tuning fork and the paper clip, and we'll talk more about them. But this is essentially what we need, and we're going to apply this concept now to evaluating measurements in the breast. Who is this person? Would anybody like to tell us who this is? This is not a very difficult question, and you see the answers right up at the top. This is Max von Frey, and he's bald because he used his own hairs to create the von Frey hairs, and he took different hairs from his wife and babies and animals and glued them to candlesticks, and he thought sensation was mediated through Druckepunkte, which are pressure spots. And this kind of concept led itself to become the cutaneous pressure threshold, which led Sims and Weinstein, Florence Sims and Sidney Weinstein, to develop the monofilaments in 1960. So they were looking for a gross measurement of evaluating sensibility, and they went to the new company DuPont Chemical, who was working with plastics, and this is the representation of Frey hairs. Now here's some questions for you. They have measurements. What are these measurements? And people think that they are, well, the measurements on the needles, they're the markings on the handles, but do they measure grams, milligrams? Because you think you're measuring pressure, but this is actually measurements of force, because that's how these were developed. What you want is something that tells you the pressure, because that's what we think we're measuring. And unfortunately, these all have different surface areas. And some of these actually overlap or measure almost exactly the same when you actually calculate them. So this is the device that we're going to be talking about. It reads out directly in pressure. The measurement number you get is grams per square millimeter. The monofilaments, the markings are the log to the base 10, or the force, in tenths of milligrams, which you then have to divide by the cross-sectional area of the filament to get pressure. And nobody ever does this. And with the PSSD, you have continuous measurements from 0.1 to 100 grams per square millimeter. These are numbers you can use to do traditional statistics. Filaments don't make an actual measurement. They give you an estimate of a range. In other words, if someone does not feel this, but they do feel this, well, their actual threshold is between those. If someone cannot feel this, but they can feel this one, their measurement is somewhere in here. It could be 50, 60, 80, 90, you don't know. But you record this, you record the higher number. So it is not the true measurement. The measurements you get with the filaments are an estimate of a range, and they're a logarithm, and they can't be added, subtracted, taken means, and put into p-values, which is sadly what everybody does. So with the PSSD, we can come up with 99% confidence limits. We can have it broken down for individual skin surfaces and by ages. And the surface is always constant. It's a hemispherical surface, which can be projected onto the surface of the skin. It does correlate with electrical tests. It correlates with hand function. The Sims-Weinstein filaments have no normative data. This may be a shock to you, but there's no normative data. In a large study of people's fingers, they might say that 83% of the people can feel this filament, and this filament became normal. But there's no confidence limit. And the same thing for the breast. So I put this in here. I never have this in my talk. Maybe all of you know Scott Levin. Today he's very famous. He did orthopedics and plastic surgery. He's the chief of orthopedic surgery now at the University of Pennsylvania. But there was a time when he was a medical student at Duke University. And he wanted to do a research project with Leonard Golder, who was the chief of orthopedics. And Dr. Golder knew my professor of hand surgery, Dr. Curtis. He sent Dr. Levin up to me as a medical student. And I showed him how to measure sensibility. And he went back with biomedical engineers, and published this paper. And it's on page 129 in the first book that I wrote. And it's available on my website free. You could download the whole book for free. But over here, you'll notice this is the marking, the filament. And here's its diameters. You can look at these variations in diameters, and some of them are very close to each other. And then if you look over here, this is the actual grams per square millimeter. So these are numbers you know. Many of the papers you will see published on the breast might have this number for a filament. But what is it? It's the logarithm of the force in tenths of milligrams. It's not a number of force or grams. It's a logarithm. So the difference between a 3 and a 5 is 100-fold. And then you have to follow this across to get pressure. So that actually all the measurements that are made would need to go to a table like this, be converted to pressure, and then be put into the statistics. I know that's a sad thought for you. So this is a new thing that I did just this morning while you were still doing surgery. You're going to see data that's the mean value of a piece of skin in the breast, and it's supposed to be the mean, but it's really the mean of the logs. And so here's an example for you. Here, say you have 3 measurements, a 1, a 10, and a 100. So they add up to 111. Their mean is 37. The logarithm of this is 1.57. That's the log of the mean value of the original data. In contrast, if you have logarithms to the base 10 of the original data, the logarithms are 0, 1, and 2. The mean of the logarithms is 1. This is a value of 10. So this is what you have to do, but this is really what's usually done. So if a log transformation of the data is appropriate, then you should typically do the transformation on the original data transformed. So here's a paper, and you know who wrote this paper, and I think you know some of the other people there. This came out in 2019. Here's the conclusion. The mean, for every month of follow-up, the mean monofilament value. See, that's totally wrong, right? Now you know it's totally wrong. And here's another paper, and I think you know who wrote this paper. And this is also very, very recent. You know, and because Valentine's Day is just in 2 weeks, I put an arrow with a little heart on it. So now what are these numbers? What are these numbers? These are the mean values of logarithms. It isn't what the skin can really feel. This is the problem. I've stopped writing letters to the editors probably 20 years ago because I just got sick of doing it. So for example, significantly lower mean monofilament values were found. You know? Significantly lower mean monofilament values were found. So that's not the way to do it statistically. Okay, now for some more fun. Who is this? This is not a hard answer. Eric Moberg started hand surgery in Scandinavia. And when I was a medical student, Dr. Curtis brought him to see me to learn how I was measuring sensibility. And Eric is most famous. He always would say Eric with a K because he published in neurology and then in hand surgery. And so we came to understand to use two-point discrimination. And he was very upset that most people would use a very pointed measurement, so they were really measuring pain instead of measuring touch. And he liked to use paper clips, but they have a barbed edge to it. And then I began to introduce vibration into sensory testing. So this was actually me, that I used high frequency and low frequency tuning forks because in my medical school class, Dr. Mountcastle taught us from single unit nerve fiber recordings in cats that there were two groups of quickly adapting receptors, and they responded to low frequency or high frequency. And this became the one for Pacinian corpuscles and Meissner corpuscles, as you'll see. And this was our paper, and I introduced tuning forks. You remember, this is just after my residency. My clinics always ran late because I was making all these measurements. The problems with tuning forks is you can't get a number. And so I introduced vibrometry in 1983, so we could do quantitative vibrometry. And this is still used mainly by foot and ankle doctors measuring thresholds in the feet. Dr. McKinnon did her hand fellowship with me in 1981 to 1982. And together we developed the discriminator. It has rounded ends, so it didn't create any pain. It was very easy to turn these things. And so we introduced the discriminator. We could also now measure moving two-point discrimination. And we'll get back to that in a minute. I introduced the moving two-point discrimination test in 1978, just as I finished my residency. I want to try to put this together in a way that makes sense for you. Susan first put these little slides together. And here we all are at 5:30. Everybody's sitting in their seat. They're happy and they're comfortable. We have a normal threshold. Everybody can sort of hear me talking. We have a normal innervation density, which means if just one person comes in and tries to get a seat, everyone will know that something happened because all the receptors are full. Now, it's a little bit later into my talk, and some people are already getting bored. They're falling to sleep. They had a tough day in the OR. They need another cup of coffee. Now we have abnormal thresholds, so I have to talk much louder for anybody to hear me. We still have normal innervation density because no one has left the room yet. The first thing to change can be threshold when two-point discrimination is still normal. And now people have had their second cup of coffee and they've had to go to the bathroom, so they left, or they're really angry at me from the things I've said. So now we have abnormal threshold and abnormal 2-point discrimination, and someone can sit down and find a chair and no one will know they're there. That's a simple way. This often comes up on in-service examinations. It's a chart I wrote a long time ago, so you can all be angry at me. People understand muscles. First a muscle gets weak, then a muscle wastes. What is the relationship in the sensory system? First the threshold will change, and then innervation density will change. So you should become just as worried when 2-point discrimination is 6 millimeters in the index finger as you are if there's thenar muscle wasting. Innervation density is to the sensory system what wasting is to the motor system. Here's the problem with classical tests. Vibration is a waveform, stimulus that will spread across the surface. The very first paper on sensory measurements in the breast was done by Julia Terzis, and she used vibration. This is really a bad idea because the waveform spreads across the skin surface. Monofilaments don't actually make a real measurement. As you saw, they make an estimate of a range. And if you use 2-point discrimination, it doesn't say how hard you have to press. We have to press a certain amount to get it, to learn really what the threshold is. It requires measurement of distance and pressure. So in 1989, I introduced the pressure-specified sensory device. It was designed by an aerospace engineer, and thank you very much. This thing weighed 16 kilograms. Way back then, doctors did not have computers in their office. It's hard for you to believe that. So it came with its own IBM laptop computer. In the top, it had its own portable printer because most doctors didn't have printers in their office. But this device is still exactly the same in all the new forms of the pressure-specified sensory device. You could also measure grip and pinch. So this is a more up-to-date version. The newest edition that was produced by the company Oxygen that makes those advanced allographs uses a Microsoft Surface, but it's still the same end device, which is right here. So this is the critical thing. And we can adjust the distance between these, and we can use just one. So we can measure 1 point moving or 2 point moving, 1 point static or 2 point static, numbers we could not really arrive at before. And so the quickly adapting fibers are the Meissner corpuscles and the Pacinian corpuscles. And the way this makes a difference for you, if you imagine you're in a car and you're riding across railroad tracks, the car's motion is this way, but every time it hits the track, you move up and down. So the Meissner corpuscles are listed right underneath the papillary ridge in the fingertips. And in skin that doesn't have hair, then the skin that doesn't have sweat glands like this, that has hair follicles, they're wrapped around the base of the hair follicles. If the hair follicle is moved, or if the papillary ridge is moved, it goes right to the Meissner corpuscles. And this will fire as soon as it's touched and then stop. That's why it's quickly adapting. And so the brain will learn a sequence, and if it goes on and off in this direction, it knows it means movement. Pacinian corpuscle is down deep, and it was thought to be a pressure receptor, but it's not. If you hold your hand up in the air and feel the air conditioner, that's a Pacinian corpuscle. It identifies high frequency. This is low frequency. This is high frequency. The pressure receptors are these Merkel cell neurite complexes, and they're directly underneath the sweat gland. And so direct pressure down will stimulate them. They're slowly adapting. From the minute you apply the stimulus, they continue to fire, but at a reduced rate. So if all of you sitting there can feel your shoes, think about it. Can you feel your shoe or your sock? That's a slowly adapting receptor. Can you feel your jacket or your lab coat? That's a slowly adapting receptor. But when you put your foot into the shoe and you feel it sliding into the shoe, those are the quickly adapting receptors. And that's the difference that it makes. One detects movement, the other detects pressure. So when we had the device, we didn't really know what we would find. And after many years of having every patient of mine measured by an occupational therapist, we were able to identify that 1 point moving and 2 point moving tell us about movement, and 1 point static and 2 point static will tell us about pressure. And then we had to learn how this related to different disease states for the nerve. So for nerve compression syndromes in the upper or lower extremity, what we found is that, in order for you to understand what we found, let me show you from experimental work. So Dr. McKinnon and I developed a model first in rats and then in monkeys for chronic compression. Silicone tube, the same inside diameter as the external diameter of the nerve was placed. If you place a narrower tube, you create acute nerve degeneration. In humans, someone may not come in with their fingers tingling in their hand for 6 months or 2 years. It takes a long time, and as you know, the transverse carpal ligament is a wide, long distance compared to the diameter of the nerve. So we used a length of tube and didn't compress the nerve. And let me show you what happens. So, normal. The black is myelin, right? And the white is the axon. This is a normal nerve. The large myelinated fibers are the A beta fibers for touch, and the small ones are the delta fibers. And pain and temperature are unmyelinated, and you don't see them because this is a myelin stain. And after 6 months, what do you see? I think everybody can see that the myelin thickness changes. We haven't lost a lot of nerve fibers. We don't have any nerve degeneration. We just have loss of myelin. And in electrical testing, that would correspond to, say for the carpal tunnel, increased distal latency, or for a nerve more proximal, a difference in conduction velocity. But we can measure this, and decreased myelin is the first thing you see with chronic compression. Then when it's been there longer, we now can see we don't have as many nerve fibers. The myelin is thinner, and we have a dropout of large myelinated fibers. Here we have axonal degeneration. And then if we operate and remove the tube, we see the nerve remyelinates, never to the same thickness. So post-operative electrical testing of a peripheral nerve that's been decompressed may always have abnormal conduction velocity or distal latency. But the amplitude should come back, which is related to the number of nerve fibers. So amplitude, the area under the curve, is related to number of nerve fibers, and distal latency is related to myelin thickness. So we can make this type of relationship. Early in nerve compression, where there's symptoms, there may not be any physical findings at all, but then once the myelin thins, we get a positive Tinel sign. And the positive Tinel sign will be there all the way around, even till they're numb all the time. And then finally, once we lose axons, we'll have abnormal 2-point discrimination. So the earliest physical finding is a positive Tinel sign, and then later we'll have abnormal 2-point discrimination. And when it finally gets out here and we've lost so many nerve fibers, we lose the Tinel sign. This is why neurologists think that Tinel signs are not reliable, but you have to relate them to the degree of nerve compression and the time course of chronic nerve compression. So first we'll get a threshold change, then we'll get innervation density. Remember me, the young medical student, tuning fork and paper clip. And now we'll be able to use the pressure specified sensory device. The pressure required to discriminate 1 from 2 will be the first thing to change, even though 2-point discrimination is normal. And you'll see this soon. So in this area where there's a Tinel sign, there'll be normal 2-point, but the pressure required to tell 1 from 2 will change. And then down here, 2-point discrimination will change. So this is in fact what we found and what we published a long time ago. And the sequence for chronic nerve compression is first the pressure required to tell 1 from 2 changes, then the pressure required to tell 1 from 2 points moving change, finally 1 point static, and finally 1 point moving will change. And so we can make these little diagrams, and it becomes pattern recognition. if you look for the index finger compared to the radial, the inner eminence, or little finger, and this is a normal threshold. The 99% confidence limit is below this black line. And red is right and blue is left. Red starts with an R, left starts with an L. But red, you can remember, red is right. So if you look at this, the only thing abnormal is the index finger threshold is abnormal. This person has early carpal tunnel syndrome, and 2-point discrimination is still normal. They don't need an operation. They need a splint or a cortisone injection. And if you follow them in time, and then this becomes a 6 or an 8, then it's too late for splinting or cortisone. The nerve fiber's dying, and they need to have a carpal tunnel decompression. You can follow the same thing for the ulnar nerve. We'll see this become abnormal. And for the dorsal radial aspect of the hand, we'll see this become abnormal. And if there's a proximal median nerve, then the palmar cutaneous branch, which arises 5 centimeters proximal to the wrist, becomes abnormal. So we'd have put index pulp, the inner eminence together. We know we have a pronator syndrome. And that's how you would apply these different printouts. And we've compared this directly more than 20 years ago to electrical testing. And the PSSD has the same sensitivity and specificity. However, it doesn't hurt. So patients will hardly ever want to have a second electrical test, but they're very happy to have repeat neurosensory testing. Now, when you're looking at the breast, you're not asking, is there a compressed nerve? You're asking, is the nerve regenerating into the piece of skin that's in the breast? So we want to look at the sequence of events in nerve regeneration. And we can measure these four things. And to come up with the answer to this, we had to find exactly the right patient. And Michael Cohen was a Stanford-trained plastic surgeon practicing in Baltimore, and he sent me a patient right after he had repaired an ulnar nerve at the wrist, so we could get early measurements. And this is what we found. So you remember from our diagram, and when I was a medical student, we published this first paper with Dr. Edgerton and Dr. Curtis because I evaluated their patients back then. Moving touch, we didn't have the computer, but we knew moving touch was the first to come back. 1-point static touch was the second to come back, because you don't need many nerve fibers for that. And then as more and more nerve fibers come back, moving 2-point comes back, and then finally static 2-point comes back. This comes back first because it's very easy to reinnervate the Meissner corpuscle. This comes back later because it's very hard to innervate the Merkel cell. So that's the answer. Now, the breast does not have great 2-point discrimination because it wasn't designed to measure 2 points. And so the breast was designed, if you think of it that way, for to release milk when the baby's head does certain things to the nipple. So it had to distinguish movement. And so we know we can measure moving touch, and we know that's the first sensation to come back. And then pressure thresholds are normally higher in the breast because the baby is squeezing and pinching on the mother's nipple, and so the static threshold is often higher. It's usually higher in every piece of skin, but especially in the breast, static 1 point is higher. These numbers may never recover in the breast because even the normal breast doesn't have much, if any, 2-point discrimination. So with the Sims-Weinstein filament, you use different filaments, and with the pressure-specified sensory device, you want to measure 1-point moving and 1-point static touch. You don't have to measure 2-point discrimination because the normal breast doesn't have anything much to do with those. I want to show you briefly how we would use this to evaluate nerve regeneration. And I see this is about 40 minutes, so we're doing okay. This is a classic problem in hand surgery. This is a patient, a 52-year-old lawyer. She fell, she fractured her humerus. She was treated without surgery in a hanging sling, which is a traditional technique. She didn't get better, so the orthopedic surgeons opened up her arm and plated her fractured humerus. And what's the dreaded complication of fixing a proximal humeral fracture? I know you all knew that. So here's this patient. You can see from her face that she's not happy. And you may remember that she's a lawyer.
How long ago did you break your humerus?
4 months.
Okay. And did it heal right away?
No, it didn't heal.
Okay, turn sideways. And after 4 months of not healing, 4 weeks ago, they operated and put in a rod. And when you awoke, were you able to use your arm normally?
No.
Okay, let's see you flex your elbow. Put it back down. And turn back around this way. Or the other way. Yeah, there you go. Okay, now bend your elbow up again. Okay. And so the brachioradialis is not working. Try to pull your arm up to you. There you go. No brachioradialis. And does your wrist lift up at all?
No.
Can you lift your fingers up at all? No. Okay.
So we measured her with the pressure-specified sensory device. Now you remember red is right, and that was her right hand. Blue is left. The black line is the 99% confidence limits. So on her left side, we have normal, 1 point static, 2 point static, 1 point moving, 2 point moving. In her right hand, where the radial nerve is injured, what do we have? We have 1 point moving is normal. 1 point static is normal. That means her radial nerve is regenerating. The sensory component regenerates quickest. And what about 2 point discrimination? Remember, 2 point moving comes back next, and then 2 point static. And the threshold is lower here, which means it's better than this. So the sequence of recovery, which is what you saw for the ulnar nerve, is exactly what's shown here. She has nerve regeneration, including she has 2 point discrimination of 6 millimeters over the dorsum of her hand. So I have to look at her, this lady lawyer, and say, based on these measurements, I believe your radial nerve is regenerating. I'm not going to operate on you. Now we have to see if our prediction is correct.
Now it's 7 months since you had the surgery on your arm that gave you the wrist drop. Is that correct?
Yes. I woke up from the surgery with it.
And our sensory test predicted your function would come back in your hand. Let's see what your hand can do today. Let's see, lift your wrist up. Good, and put it down. Give me a little wave. Great, and turn sideways. Turn your body sideways. Turn your hand sideways. Yeah. And now just make a fist and then straighten your fingers out. Straighten your fingers out. Great. Make a fist again. Stick just your index finger out. Okay, let's see your little finger stick out. Let's see your thumb hitchhike. Great. Let's give us a big thumbs up because it's working now. Okay. Are you happy?
Yes.
Okay. Now it's 7.
Okay. This is our next and last patient. 54-year-old orthopedic surgeon. Oh my, a surgeon. He fractured his humerus when he was 18. And it did heal. But 2 years ago, he began to have posterior interosseous nerve dysfunction and wasn't able to operate. And his partners carried out a neurolysis of his posterior interosseous nerve. He got better and then he got worse. And 3 months ago, they repeated the neurolysis of his posterior interosseous nerve. And what do you think happened? It's pretty sad when you operate on your colleague and tell him after that that he's never going to be able to operate anymore. And so here he is. He came to see me.
It's 3 months following an exploration of the radial nerve, and there was a radial nerve palsy. Try to extend your wrist. And the wrist does extend related to the extensor carpi radialis brevis.
You can see the radial deviation of his wrist.
Let's try finger extension. Lift up all your fingers straight out. And notice that some finger extension is obtained by flexing the wrist and using the intrinsic muscles. Let's turn around and see what happens to the thumb. Let's see, pretend you're hitchhiking. Lift your thumb out. There's no extensor pollicis longus function.
So now, as you know, we're going to do
3
a
months.
pressure-specified sensory device. Now, if we look at him, you could tell it was his posterior interosseous nerve that wasn't working so well. And it was his left hand. So now we're looking at the blue that's going to be abnormal. The red has all normal measurements on the right side. And the blue, he has 1 point static and 1 point moving, which suggests nerve regeneration, but he has no 2 point discrimination at all, which means significant axonal loss. So in his case, we're taking him to surgery. Now, here's the posterior interosseous, there's the radial nerve, the radial sensory. Down here is going to be the PIN. Now, do you remember he had an injury when he was 18 years old? And so I did the neurolysis in this area, which in and of itself was pretty risky to do. And then here's the radial sensory and the PIN, but we still couldn't get electrical activity. So we have to move forward, more proximal. And here is his old humeral fracture. And here he has a big osteophyte that was causing compression across his radial nerve at the site of his healed fracture from when he was 18.
When was this operation that you awoke from and couldn't lift your wrist or fingers up?
That was February 7th, 07.
Okay, and then how long after that did I operate on you?
May 3rd, 07.
May 3rd. So it's about 3.5 months since I operated on you for your radial nerve palsy, and you'd had 2 operations prior to mine. It was after one of those when you lost your function completely. And now let's see, can your wrist bend down and up now? Lift it way up. That's great. Okay. Pull your fingers in. And let's see you straighten your fingers out. That's great. And turn your hand over and let's see if you can, like hitchhike. Bend your thumb down. Flex your thumb, lift it up. That's great. Now let's see if you can move your index finger, extend your index finger while your other fingers are closed. Great. And one last one, lift your little finger while your other fingers are down. That's really good. Okay, thank you.
I'm happy to say he went back to his
when
practice
was this
of orthopedic surgery. Now, who learned the answer? Did you all figure out the relationship between this and the post-operative? You didn't think I would learn that Maastricht is in the province of Limburg, but I wanted to show you that. So we can end the talk now, and there should be 10 minutes left for questions before you go out to start to have your first drink.
Thank you, Lee. It's incredible. We go back to our data and I come back to you. Is that right?
Okay, so that was my talk. Does anybody have any questions? Nobody has any questions?
Yes, I do.
Dr. Lucas?
Yeah. Thank you very much for the very interesting talk. As I didn't present myself, you probably don't know that I'm busy doing QST quantitative sensory measurements myself, but that is from the neurophysiological point of view. And I was actually trained indeed in doing neurological examinations with the old-fashioned way. But there is further developments of the Van Vrij hairs, and also for the pinprick detection thresholds, where we use like standardized instruments from MRC systems. Are you familiar with those?
Yes.
Yeah. Okay. Because they made these instruments in a way that you have the size of the tips is standardized, so you can really measure the pressure you put on this hairs and on the pinprick.
If I had had more time, for the talk, but I want, the timing turned out okay. When I talk about the pins, especially in front of hand fellows, I tell them there are actually 2 times where I do use pain. But if you're for nerve regeneration, even if you're a very, very bad surgeon, you can hook 2 ends of a nerve together, and patients recover perception of pain, hot and cold, small nerve fibers. But maybe for the residents that are out there, and we'll let Ann answer this question if nobody else answers this. I'm often sent a patient who they'll show me has ulnar and median innervated intrinsics, and they send the patient to me and say, this patient has median and ulnar nerve intrinsics compression, and it's very bad. They have all their intrinsic muscles are wasted. And then I test them, and they have normal 2-point discrimination in their index finger and their little finger. So there's a rare condition where you have normal sensation but no intrinsic function. The patients, however, cannot perceive pain. So it's a dissociation of pain from touch. Do any of you know what condition this would be? Because you don't want to operate on their peripheral nerves. You want to send them for a 3T MRI of their spine and then send them to a neurosurgeon to have their what? Decompressed. It sounds like that big thing that's in Egypt, the Sphinx, but it's not a Sphinx. Okay, if you have a cyst in your spinal cord and it grows forward, which is what a syrinx does, it puts pressure on the ventral horn, so you lose motor neurons, and it presses on the anterolateral spinal thalamic tract, so you lose perception of pain. And it preserves the posterior conduction of touch. Right, so I've had 2 patients like that, and they had a syrinx in the cervical spine, and the neurosurgeons decompressed their syrinx. Is that good, Dr. Lucas? That's the use of pain. The other time is if you think the patient's lying to you. They're in a car accident and they go to the insurance company, they want a lot of money for disability, and you don't believe that they don't have any feeling in their hand. Then you put one hand under their hand and you stick them with a pin, and you can feel them pull their hand away from you. So if you suspect malingering or if you suspect a syrinx, those are the only 2 times I actually stick my patients with pins. But I'm not a neurologist. The neurologists have much more reason to stick people with pins because they like to hurt patients. No, just kidding. Okay, do I have any other questions?
Yes, I do.
Okay, Hansi, what's your question?
We are about to implement the PSSD in our clinical trial, Dr. Tuinder's clinical trial, about sensation after breast reconstruction. And we were wondering, so we are measuring with the PSSD on a continuous scale. How do you handle data? Well, there's a measurement threshold. Of course, there's a maximum force that you can exert on the skin. How do you handle data that exceeds that threshold? What would you do with that?
It is, of course, possible excuse me, to take a rounded probe and push it directly through the skin.
Yeah.
Then, so the answer is there is no recovery then.
Mm-hmm.
And so, like in a finger, if 2-point discrimination is more than 15 millimeters, there is no 2-point discrimination because the finger is only 8 or 9 millimeters wide. And in the old days with Dr. Moberg, they'd measure from the tip of the finger to the first phalanx, and they'd say there's 20 millimeters, but it's really a ridiculous number. So for practical purposes in the fingertip, if you can't feel 10 or 12 millimeters, or in the toe 15 millimeters, we say there is no static 2-point discrimination. In the breast, if you exceed 100 grams per square millimeter of pressure, either for 1-point static or 1-point moving, you should record it as no. And the software is supposed to write the words no on the computer printout. Because if you just get a printout and there's no measurement recorded, you don't know if the testing person failed to do it or it just didn't record it. So if you can print it out, and nothing prints, you should write no moving or no static 2-point discrimination. And in the method section, you just write greater than 100 grams per square millimeter of 1-point moving touch was taken to mean no moving touch had recovered. And that's your definition of what you're doing.
Yes, okay, clear, thank you.
Well, that was a very basic approach to touch, but most people really don't understand the relationships between what we can measure and how it relates to nerve compression versus nerve regeneration. And I think this will help you in interpreting papers. Now, perhaps you know the company Axygen is very interested in reinnervating breasts because some people use their advanced allograft to connect the flap to the nerve. And so they have, I think it's 12 centers that are maybe for a year now have been measuring using a pressure specified sensory device. So there's a truck going by my house. You can hear the noise. So my hope is that in perhaps another year or 18 months, if someone does a meta-analysis, they'll be able to put papers that have made actual true measurements with a pressure specified sensory device or whatever you want to call it. And then they'll be able to do a meta-analysis and compare the numbers. The ones that have been reported with Sims-Weinstein, and maybe for Hansi's PhD, she can go back and look because the meta-analysis that came out that Dr. Serletti did, and I think they only had 37 papers, so it isn't so many papers. You can see if statistically, methodologically, there were some that really were doing statistics on the numerical marking of the filament versus any who actually figured out the actual pressure and then did the statistics on that. And then you can come up with a new meta-analysis of papers that were done doing the statistics the correct way. There's a separate paper we wrote with Keith Brandt on the logarithm measurements. You can only find out in Sims and Weinstein's book in 1962, it's Appendix B at the end of the book where they actually tell you it's a logarithm. It would be it'd be a good part to your PhD. I think you need 5 or so separate papers. This is one you could do probably in a week or 2 or 3 weeks, looking at those papers, separating the ones who actually evaluated the filaments so that they entered a number of pressure into the statistics rather than the filament marking. And you would bring to modern day recognition the problems with filament testing, and that would serve as a basis then for subsequent papers you would write evaluating them in the correct manner.
Yeah.
I have a question for you, Lee, because you said there are these centers just doing the innervation of a breast with a graft, with an allograft. There are people saying that this is better without presenting any data, because in the regeneration of the sensitive nerves is even better to have a gap between the nerves. I cannot explain that by myself. I think that if possible the direct coaptation is always better than a graft. If you look at the data at the end on hands and so on, what do you think about that?
Okay, first I should ask you this question because I don't know. Usually I always ask questions and I know the answer, but I don't know the answer to this question. After there was a time when we had a woman resident, Sherry Slazak, and she published the first paper of an innervated tram flap with me. And after that, Philip Blondil, who's very close to you in Ghent, right? He published the paper on reinnervating the breast with the fourth intercostal nerve. And then after a while, he stopped doing it. I wonder what he does today. Do you know, has Philippe Blondil and his group, have they started to reinnervate the deep flaps, and do they use the fourth or the anterior branch?
Well, I don't know from Blondeel, but someone from his group, Van Landuit, is just doing reinnervation in the same way we are doing. So not directly using the fourth lateral intercostal, but just the second of the third medial intercostal branch.
Okay, so thank you for that. I think if somebody is going to do the next meta-analysis, let me see if anybody in the group knows the answer to this. What is the difference between the number of axons you would have to reinnervate your flap if you used the fourth intercostal versus the anterior branch of the intercostal? Has anybody calculated those nerve fibers?
Well, I do know that the lateral cutaneous branches are way thicker, so they probably also have more axons.
Right. And so one of the factors that has to be taken into account in terms of you probably should not try to compare the results from a fourth intercostal innervation versus one from the second or third interspace, because they're different number of axons, and in an experimental model it should make a difference. It may be a difference of 800 axons versus 200 axons. And that would be another interesting, if you can't actually find those numbers, that would be another very simple, just from, in the operating room, when the breast is resected, to take a branch from the fourth intercostal versus or your actual operation. You come up with what those numbers actually are, because that has to be taken into account. For example, we did a paper similar. Do any of you know in Taiwan, the most famous microsurgeon, Fu Chen Wei? I've been visiting professor there many times a long time ago. He was most famous for taking the toe and making it into a thumb, the toe to thumb. And he'd had beautiful cosmetic results, but his sensory recovery was not very good. And I discussed that with him, and he became very angry at me. And so we worked together, and he would implant then the dorsal branches to the thumb and the volar branches to the thumb, and he would include the deep perineal branch to the toe transfer. So we're adding more axons, and we have a paper published where we actually know the number of nerve fibers put into the transplanted digit and the outcome in terms of two-point discrimination. And the more axons you had, the more two-point discrimination you got, which makes perfectly logical sense, but it's a lot of work to prove that.
But Lee, sorry if I interrupt you, but don't you think that because you have, it's depending also on the donor nerve from the abdomen, do you think that it's besides the number of axons also, I mean, if you have to use a graft to reach the lateral intercostal nerve, would that have an impact on the results and of the axonal count, I think? Then if you do a direct coaptation?
The answer is yes. So now I'll answer the question you first asked. I guess in the year, you may know that I invented the first neurotube, first conduit for nerves to grow through.
Yes.
And the point of that was, if you put a nerve in one end and a nerve in another end, it doesn't have to go through suture lines where you lose numbers of nerve fibers. And you know your friend who lives right near you, Goulinx, Philippe Goulinx?
Yes.
He was the first one in Europe brave enough to use one of my tubes. and he showed that it worked quite well. And then we had to have a study to get it approved for use in the United States. And it was the first randomized control trial for a peripheral nerve. And Susan and myself were not allowed to be authors because it was an ethical conflict of interest. So my name and Susan's name is not on the first paper. The first paper is in the year 2000, and the first author is Robert Weber. And it actually showed that leaving a small gap, connecting a nerve, not end to end, but with 2 or 3 millimeters space between them, if you will, a small conduit, or, for example, something called a connector, which oxygen makes a connector. Not a wrap. You need to leave a little space, that you got statistically significant better sensory recovery from putting a nerve together with a gap than by a direct primary suture. And that study from 20 years ago means that if you are in the operating room and you have the fourth intercostal nerve, even if it reaches the DIP flap nerve, you should connect it with a connector. When I operate on somebody and repair a nerve today, I still will hook a connector. And the only question that isn't answered is if you use a graft. You need a connector at each end, not a wrap. You have to put the nerve 2 or 3 millimeters away from the other end of the nerve and stitch the nerve to the connector, and you leave a gap there. And it's a little bit extra work, but the only evidence to answer your question is from that study. And no one will ever do another randomized control study. The patients went into the operating room, they had signed the permission slip. You opened up their hand, you saw it was the nerve cut. If the nerve was actually divided, you pulled an envelope, and it said whether you were going to do a primary repair or a conduit. And that was randomized in the operating room. I don't think anybody else will ever do that. We had 5 different centers. Each center had a past president of the American Society for Surgery of the Hand, and that's what we came up with. So that if you're in the intercostal space where you're operating, and there's not a very big length to the nerve, and you don't want to use an allograft, you can still use a connector because the evidence shows a connector is best, and it actually will gain you 2 or 3 or 4 extra millimeters of length, so you don't have to have any tension if you did have tension. So there are a lot of different variables. And there's a study we did with somebody named Jim O'Brien, who's chief of plastic surgery in Canada now in Newfoundland, St. John, Newfoundland. And this is going to answer your question. We took, in rats, we overpacked the number of axons. And so we took, you can have, the sciatic nerve, of course, has a tibial and perineal component. And so we took, say, the whole sciatic nerve and just sutured it to the tibial nerve. We sutured just the tibial to the tibial or the perineal to the tibial. And we got ratios of 1-to-1, 2-to-1, 3-to-1. And you could increase the number of axons that come out the distal end by increasing the number of axons you put in. So that sort of answers your question a little bit. Well, I know everybody's ready to go home and have their first glass of wine. Or maybe you beer first. How do you say it? Bier auf Wein, das ist fein.
Yeah.
Beer before wine is fine, but beer after wine, das ist nein. What is that?
I don't know. May I just ask you a last question?
Yeah.
So because I knew the paper of Weber, but I didn't know that you were behind. But the question is, if you have 2 possibilities, just a coaptation with 1 connector, for example, and a coaptation with using a graft and 2 connectors, you will lose axons load, I think, if you use the graft. Is that correct?
Correct.
All right. So that was my question. We don't use a connector. You know why? Because for actually money problem, because the insurance is not paying for that. And so the only possibility we have to give a reinnervation to our breast at this moment is just a direct coaptation. And if we really can prove at the end that anyway innervation of a breast worth it, then we can go further and we can ask even for a connector for our reconstruction. So, but I come back to you with our data.
Okay, but I tell you, I give you a suggestion. I don't like to use veins.
No.
But, David Chu in New York and Barry Strauss, they liked veins. And when you're in the abdomen harvesting your flap, you'll come across many veins. You can take a small vein, and you could use the vein as a connector. I think for a distance of only 2 or 3 millimeters, the vein won't collapse. I didn't like to use veins for 1 or 2 or 3 centimeter defects. David Chu still would do them, but he wouldn't do it for his index finger or his thumb. He would do it for a non-critical sensory area. But the same way you could take a vein graft for a vascular reconstruction of an artery, you could try it. No one has actually tried using a vein graft as a connector for a small gap. It could be a separate PhD study for some student.
Or perhaps an artery, because it doesn't collapse so easily.
Yeah.
Right. Thank you so much for this knowledge. We can just stay and listen to you a couple of hours more. I think.
Okay. You could invite me. We have I've been thinking about this. A virtual visiting professorship. If I were really there, I might give a second lecture. We could have another lecture on pain for Dr. Lucas, chronic pain, and we could include some pelvic pain. And then one day when everybody has their vaccination, I now have had my second shot. Luann and I will come over there. We have lots of friends. We could have just a cadaver, dissection day to look at joint denervation or some other nerves. And then you can introduce me in person to your friends.
That's a very great news. We will absolutely do that. And now we are only trying to give you a distance visiting professorship, and then we will try to organize it. But if you want to, if you are able to give another lecture, I think that Dr. Lucas and Dr. Sommer will be very, very happy about that.
And you saved a lot of money, because you didn't have to pay for my airfare or my hotel with all the wine that I would drink at dinner.
Yeah, that's right. We will do that with pleasure. So, yes.
Thank you very much.
Thank you.
What do you say? Dank u veel? How do you say thank you in Dutch?
Dank je wel.
Well, bye.
Bye.
Thank you. Bye.
Moet ik die schermopname nog
Als iedereen
stoppen?
nou 1 keer lukt of niet? Of er alleen bij?
20 mensen.
Toch 20? Oh, dat is nog netjes, hè? Grappig dat hij dat van die artikelen aanhaalt. Maar daar heb ik 4 jaar geleden al naar gekeken en dit is echt verreweg de beste optie die wij hadden. Om de monofilament waardes te nemen.
Je gaat
Duurt
terugkomen.
misschien eventjes.
Met
Want het is heel lang.